Welcome to our podcast episode on immunotherapy treatment and biomarker testing for metastatic cervical cancer. I am your host, Anna Christofides. Our guest for this episode is Dr. James Bentley, who is a professor and head of the Department of Obstetrics and Gynecology at Dalhousie University, Halifax, Canada. Dr. Bentley is past president of the International Federation of Cervical Pathology and Colposcopy and the Society of Canadian Colposcopists. He is also past president of the Society of Gynecologic Oncology of Canada. He serves on numerous national and provincial committees involved with cervical cancer screening and gynecological cancer. Hope you enjoy it. So thanks so much, Dr. Bentley, for joining us today to discuss immunotherapy treatment and biomarker testing for the treatment of metastatic cervical cancer. So to start, I wanted to ask, what is the standard treatment for recurrent or metastatic cervical cancer, and how effective is it really?
First of all, thank you for inviting me to be part of this series of talks. A pleasure to be with you. So currently, we've evolved over the years. In the years I've been in practice, I've almost gone from very little therapy to offering cisplatin alone. And more recently, everybody getting carboplatin and paclitaxel as their standard of therapy. There were trials done that sort of looked at the increased survival with all of these different modalities. And we saw that with cisplatin alone, you had a 20% response rate and a progression-free survival of between 2 and 3.2 months and overall survival of up to 8 months. And then you added in cisplatin and paclitaxel, and the response rate went up to nearly 30%, 29%, but the overall survival only went up to 12.8 months. So there was a doubling of that with a platinum and a taxane. And in reality, because of the toxicity profile, most of us would use carboplatin as a replacement for cisplatin and using standard gynecological doses for these drugs.
I see. Thank you so much. And is there been any sort of improvement with the addition of bevacizumab to therapy?
So the standard of care was changed a little bit with the addition of bevacizumab into the armamentarium. So bevacizumab to carboplatin and Taxol. And when we sort of had a trial where we looked at adding it in, it did improve the outcome. In that trial, which was led by Tawari et al., they saw that the overall survival advantage did increase by about another 3 months. So it did improve the progression-free survival and the overall survival. The challenge is that the toxicity of therapy can be significant in the previously irradiated patient population. Whereas in the trial, they saw sort of fistula rates of GI and genitourinary rates together of about 3%. I would suggest that most of us in our clinical practice see that as at a higher rate, and trying to treat fistulas post-radiation in a patient with recurrent disease is a very challenging situation and affects patients' quality of life significantly. This is on top of the hypertension, which occurs about 25% in the proteinuria. I think it was a high dose of bevacizumab, but we sort of may modify that. But that gives us a little bit of pause in these patients.
That seems very challenging, and it does seem like that might be an unmet need for patients. Are there any other unmet needs that come to mind? And then how do you think the treatment could be further improved?
Well, it totally is an unmet need. This is a disease that affects young women, and there's a loss of lives lost because of recurrent cervical cancer. And we've all dealt with patients in their 20s, hopefully going away because of vaccination, but we're still going to have cervical cancer around for many, many years. And as I said, these are young patients, and when they recur, it can be very painful. And anything that will improve the outcome is really a welcome addition to our armamentarium. So when people started looking at the addition of immunotherapy to this, that was very hopeful. There are groups that have looked at adding longer duration of chemotherapy, such as the Outback trial, that didn't really help anything after standard radiation therapy. So new drugs are very, very, very welcome in this disease.
Yeah. And so what is the rationale for targeting the PD-1, PD-L1 pathway to treat patients with cervical cancer?
So there are people that have speculated that cervical cancer as a infectious disease caused cancer, which obviously has an HPV virus, and your body's immune response to that virus and how it allows that to actually take hold translates into the immune system being activated. And would checkpoint immune modulation really be useful in that setting? Having said that, one Keynote 158 trial was a basket trial. So we do know that pembrolizumab was active in many different situations, but it obviously did seem to be active in this setting.
So what percentage of cervical cancer patients do you expect to be positive with the 22C3 clone? And how can you monitor this key parameter as well?
So when you're looking at immunotherapy, and I don't really know all of the background of all of the other disease sites, but obviously the PD-1 score and assessment is an integral part of seeing who is eligible for this therapy. And that's part of looking at is this some sort of personalized medicine which could allow us to tailor the chemotherapy we use to the patient that has the disease. So when people have looked at this, they looked at the PD-L1 count and scored that on the combined positive score, CPS score, greater than 1 and greater than 10, and that is what is reported in the trials. And as the score goes up, the response is better. The Keynote 158, the original phase 2 basket trial, had a smaller number of patients, but they had about 83% of patients that had positivity with a score greater than 1. In the 826, they saw that 89% of people were positive with this PDL score 1 greater than 1. I should note that as a clinician, I think this is quite confusing, and we rely on our pathologists to help us with this. And I am told that there's multiple different ways of counting PDL1 score, depending on the tumor site that you're talking about. And the process is dependent on different antibodies that are used and a specific machinery that is used. And the testing that was used for this was using a 223C antibody clone on a specific machine and requires sort of certification of testing, and then is counted in a slightly different way than scores counted in lung cancer, for example. So there's some nuances in that we as clinicians need to know about and to think about when we are contemplating using these drugs and how and when we get a biopsy.
So how can you monitor for this parameter? Are there certain points in the treatment pathway?
I think most of us would probably, and I don't know how this is going to pan out over the next while, but it doesn't seem like it's something you're going to need to do up front when you do initial therapy. But you need enough tissue to do this testing on. And I think it has to be on tissue. You can't rely on cytology for this. And you can't go back and get a sample inside a radiation field. So if radiated tissue is not a good sample for this. So I think we need to sort of be cognizant of that. And so when we are getting our initial diagnosis, we need to make sure we have a good biopsy. Because sometimes when you've got a big cancer, you'll take a biopsy and you'll get, it looks like a cancer, you know it's a cancer, you use a standard cervical biopsy forceps, and unless you go deep into the tissue, you end up with just pre-invasive disease, and you end up treating on that because you know that it's a cancer and everything else suggests it is. But it may be worthwhile actually getting a small leap specimen at that time to get a good tissue sample so you've got some in the bank so you can get this testing done later on. Because otherwise you may be looking at metastatic disease in a paraortic area, in a lung or somewhere else that you need to get a core biopsy on to actually test for the patient. So it'd be better to have a bigger sample initially if it isn't a patient that's had surgery and then recurred after surgery, bearing in mind that they're going to get surgery, then radiation, and then chemotherapy for their second recurrence, most probably.
Right. So it seems like getting the sample in a timely way is one of the challenges. And what are some of the other possible challenges with PD-L1 testing?
I think there is that challenge that your pathologist needs to be comfortable with doing this and being trained on this particular methodology. I know in our center, the pathologists are being trained, but we're also using the standard test that was in the trials as a sort of validation test as we go through this. And I'm not sure how many samples they'll need to do to validate that, but there's some internal validation that centers are going to have to do about this. And these are small volumes of patients in any one center.
And in your center, what sort of percentage are you seeing that are positive?
Well, I can't really give you a percentage at the moment because
Of course.
we're early days in this. So,
Yeah.
I do know there's recent cases that are positive. Yeah. So we would anticipate, I don't see anything reason why it should be different from that 89%. So somewhere between 80 and 90% is going to be positive, I would anticipate.
So in terms of the immunotherapies, which ones have been examined in metastatic cervical cancer?
Obviously, pembrolizumab, and the other one that is sort of available on compassionate access at the moment is cemiplimab, durvalumab. But obviously, there is activity in this disease process, and hopefully there'll be more options for our patients as time goes by.
So in terms of where we are with these agents, what have some of the recent studies examining them shown us? Maybe you could discuss some of the results of some key trials.
So, I think if you go back sort of to the Keynote 158 trial, which was the basket trial, and that basically showed there was a response rate of 12.2% to 14% in recurrent or metastatic disease. So that was pretty reasonable and enough to sort of recommend usage in the States, but it wasn't enough to get approval in Canada. And I believe in that particular trial, there wasn't much adenocarcinomas in that trial. So, it didn't give us much information about that. So some of the initial recommendations didn't include adenocarcinomas. Whereas in the Keynote 826, there was 617 patients and randomized, of which 548 had a PDL1 score greater than 1. That was at 89%. And they were randomized to platinum-based therapy with chemotherapy with either pembrolizumab or placebo, plus or minus bevacizumab. I believe about 30 to 40% of patients got bevacizumab in the trials, which is significant, and they were then followed. So they, in their trial, they had 76% squamous cell cancers, which is about what we would expect in clinical practice in Canada. So they randomized these patients, and then they followed them as you would do with regular imaging and clinical examinations. And they saw in the patients that had a score greater than 1, the progression-free survival at 12 months was 45% versus 34% in the placebo arm, with a hazard ratio of 0.62 and confidence intervals which were pretty tight at 0.5 to 0.77. So they put all comers in. They saw the same sort of response, and they also saw a better response with a hazard ratio of 0.58 if the score was greater or equal to 10. If you then looked at their overall survival, at 12 months, the overall survival was 75.3% versus 63%. And at 24 months was 53% versus 41%. So if you sort of means there's a significant difference, in those rates compared to what we've been doing with carboplatin and Taxol, and also to doing nothing or with cisplatin as we were doing many, many years ago. So a significant advantage here. And the hazard ratios are about 0.64 with confidence intervals of 0.5 to 0.81. So a good response in those patients that had a CPS score greater than 1. And if it was greater than 10, it was even better than that. So I think this was a uniformly positive. You can get your thumb test on, you can see the gap between the survival curves, and a welcome addition to our armamentarium in this disease. The other trial that is out there is the cemiplimab, and this was published in February of this year. This is cemiplimab versus chemotherapy for recurrent disease, post-platinum-based chemotherapy. So these patients had actually had carboplatin and Taxol or other therapies, and then on their second or so recurrence, they were randomized to further chemotherapy versus the cemiplimab. And they saw a benefit in this patient population with our overall survival benefit, with median overall survival being 11 months versus 8 months in the squamous cell carcinoma, and 13 months versus 7 months with adenocarcinoma. So overall, about 12 versus 8.5. So another immunotherapy that showed an advantage. And it's always interesting when you look at these survival curves and think of this population and how we see them. There's very, very, very few long-term survivors in any of their clinical practice in this patient group. But in the trials, there is always a tail of patients that seem to be alive at sort of 2-3 years, and the continuing separation of the survival curve. So you might you always hope when you treat somebody is they're going to be somebody that responds really well to immunotherapy and they can carry on for a very long period of time. And who knows what comes down the line. But there is a hope that you might get a lot of patient that survives longer than you would normally see.
Right. Yes. No, that's very encouraging. And so thinking about these different trials and the data that has come out so far, which of the studies do you feel might impact clinical practice in Canada, and how so?
So I think as we sort of go in the early days of immunotherapy in cervical cancer, I think the number one thing is we want to give the best therapy to the patients when they are most able to tolerate it and they're going to get the best response rate. So I think from my perspective, I think using pembrolizumab with chemotherapy at their first metastatic recurrence or non-irradiable recurrence is probably the best bang for the buck, shall we say, and it's going to be the one thing we think about in that setting. Now, if we've got patients that have had chemotherapy already, I think we would all like access to immunotherapy in that setting for a second recurrence, and using it on its own may be beneficial. And what is available at the moment might be the cemiplimab, or was available through compassionate access. So we do need some consistent access to these drugs so that patients can probably be offered them once in a course of disease. And hopefully there will be other options that come down so that we can use the chemotherapy with pembrolizumab initially and then have something else later on as a second recurrence, because again, that's going to be a real challenge.
Yeah, for sure. So what is the next step in ensuring patients with metastatic disease have access to these therapies?
I think that's a challenge. At the moment, it's going through Health Canada for approval, and we have to hope, and I think we understand there's an unmet need here. There's a significant unmet need, and it's a significant in young women as well. So I'm hopeful that will go through all the economic processes, and then it'll be approved in all provinces, and then go through INS in Quebec, and then we'll all have access to it via the provinces. And then, we need to make sure that women who have recurrent disease are seeing somebody that knows that these are therapies and knows that this is becoming a standard of care, so that they get offered appropriate therapy and then get the appropriate testing. So I think we need to be sort of centralization of care, as is done in most gynecologic oncology patients, is beneficial in that we all hopefully are on a similar understanding of the disease process and what are the options are. So I think that'll happen very quickly, because I think we all understand the challenges of recurrent metastatic cervical cancer and the devastating effect that it has on young women and on older women.
Oh, thank you so much, Dr. Bentley. Is there anything else you want to add on this topic you think we should bring up here?
I think sort of the number one thing when I look at this is sort of, we need to think about this, but we probably need to think about this right from the beginning. I don't think we need to get the PD-L1 testing done right away, but we need good tissue samples so that we can then use that in the future for patients, so that we know where we're going if we get a recurrence. So, if you've got somebody that's coming in with a stage 3C disease, you know that a percentage of the time you're going to go down this road. So make sure you got a good tissue sample.
That's a really good point. Well, thank you so much, Dr. Bentley, for this really informative talk. I think it's been really helpful for our listeners, and I really appreciate you coming today.
Thank you very much. It's been a pleasure to be with you today.